Okay, good afternoon, everyone. I'm Patrick Honorè from the UCL University in Montgadin in Belgium, and my co-chairman is Professor Ricard Ferrer from the University Hospital of Vall d'Hebron in Spain. So we are very pleased to chair this session organized by Estor with a very interesting program. So with any further ado, I will welcome the first speaker, Professor Giuseppe Castellano from the Milan University Policlinico, and he will speak about highly hemocompatible membrane to bridge renal recovery in acute RRT.
Dear moderators, thank you very much. So we will start today talking about aging. Why we will talk about aging? Because I will show you some data that renal disease is a special form of accelerated aging. In this, the FEBS journal cover, you can see the aging cells interacting with an old cell home. And I will show you some data showing that acute kidney injury is a model of accelerating aging, where several cells of the kidney will go under senescence. And we know that a special pattern is the acute kidney disease, and we have different possibilities. We can have a full recovery, or we can have an organ death in dialysis. In the between, there is a maladaptive repair with several mechanisms of activation. And these are really new data speaking about the kidney matrixome. So the kidney matrixome in health and aging really will explain why there is a maladaptive response. And in this matrixome acting at the level of the kidney, you can see that there are complement components. So there are molecules of the innate immune system that are overactivated in this setting. We know that in the physiological phase, there is an interstitial matrix, the basement membrane, the glomerular basement membrane, where there is a special collagen, the collagen 1 and 3, the elastin, the collagen 4. During disease, there is renal aging. And this is an acute form of disease in which, for example, at the glomerular level, there is a downregulation of collagen 4 and upregulation of collagen 6. And at tubulointerstitial level, there is upregulation of TGF-beta or elastin. What is interesting is that also in other organs, the aging phenomena, like in ischemic heart or in fibrotic liver, are exactly the same. So if we have some drugs interfering with this process of aging in one organ, we can expect that this drug will also work in other settings. Though about the complement, now we know that the complement is bad for aging, and this has been demonstrated in different settings, like in Alzheimer's disease, in age-related macular degeneration. And also recent data put the complement in the uremic toxin. So we can really say that complement is an uremic toxin, because recently complement factor D and complement like pentraxin 3, that is a complement activator, has been recognized as uremic toxin. So we have to be careful that these systems are not activating in acute setting. We know that hemodialysis membrane surface are powerful, the normal hemodialysis surface are powerful activator of complement like C1q, MASP, so the classical, the lectin pathway of complement are activated. So during dialysis, we have an overactivation of the complement system. And the consequence of complement activation is fibrosis in different settings, in renal ischemia reperfusion injury, but also at vascular level. For example, we have demonstrated that complement induces endothelial to mesenchymal transition. Here you can see that LPS is capable to induce endothelial to mesenchymal transition with complement activation. And in this process, endothelial, they acquire the pro-fibrotic phenotype. And also, LPS and complement are capable to induce pericyte to mesenchymal transition. And when a pericyte is transformed in myofibroblast, it's very difficult to make this process revertible. It's almost impossible because you have fibrosis. And as I told you in the beginning, we have also clear evidence that during acute kidney injuries, complement can induce aging, senescent cells. You can see here that C5a is capable to induce strong senescence in tubular epithelial cells, and in in vivo system, which we inhibit complement, like with C1 inhibitor, we have inhibition of senescence. So complement activation during acute kidney injuries can induce renal aging at endothelial level, at pericyte level, at tubular epithelial levels. We have the induction of senescence by different mechanisms. So endotoxin can also induce, we know, complement activation and coagulation activation. We know that these systems that are fully of proteases can interact one on the other. So complement and the coagulation system are capable to activate each other, I would say. And this will end in endothelial dysfunction and multiple organ dysfunction. We know that LPS is a powerful activator of complement, especially of the complement alternative pathway by the lipid A. So, talking about dialysis, we know, as I told you, that dialysis can activate the complement system. But we are talking about the dialysis with the classical filter. We see that different filters like polymethyl methacrylate can have an adsorption capacity that is really strikingly higher. You can see here in a gel, these black dots are all the protein that are absorbed by polymethyl methacrylate. The polysulfone cannot absorb. So we can expect that in this absorption, you can have absorption of the molecule of the innate immunity. And we know that during dialysis, in acute setting, in a chronic setting, we have to be careful to activate complement. We have to remove complement because otherwise we have activation not only on renal parenchymal cells but also on leukocytes. And with this hypothesis, we studied a new approach, investigating a new pathogenic mechanism in a swine model of LPS-induced AKI, testing the polymethyl methacrylate membrane on a CVVH approach, and we study the activation of the systemic and the tissue immune system to see whether this new membrane can have an immune modulatory effect. This is the animal model. We had LPS infusion, and then after 3 hours, we start CVVH with polysulfone-based or polymethyl methacrylate. And then at 10 hours, we stop the treatment, and at 24 hours, we sacrifice the animal, and we analyze all the tissue, but also the leukocyte of the poor child leukocyte with the omic approach, with the microarray approach. Starting from the investigating the renal function, the oligoanuria, and testing the hypotension, you can see here that the urinary output is better, significantly better in PMMA-treated animal, but also the mean arterial blood pressure is significantly higher when compared PMMA with polysulfone-based CVVH. But next to functional data that are really interesting, we can see that the infiltration of leukocytes in CVVH used by PMMA is really less. So when we use polymethyl methacrylate CVVH, we have reduced leukocyte infiltration into the kidney. And what you see here also, that we see renal fibrosis that is significantly less in PMMA-based CVVH. In polysulfone-based CVVH, you can see here this color that are collagen fibers. On the right part, with PMMA, you almost do not see collagen. when you see less collagen, you see less aging, you see less senescence, because as I showed you at the beginning, more collagen, it means more collagen deposition, more senescence, more myofibroblasts that are activated. But when we analyzed the activation of complement at tissue level, first of all, pentraxin 3, that is a new uremic toxin. You can see also C5b29 in the lower phase. On the right part, you can see that the PMMA almost does not contain the deposition of pentraxin 3 and C5b29, indicating that with this filter, we can absorb complement component and there is no activation of the complement system. And these are quite striking if we compare with the polysulfone-based CVVH. So, complement activation, we should study not only at tissue level, but also at systemic level. And we can see here that with the PMMA, we have a striking inhibition of the classical pathway here, but also of the alternative pathway. As I told you, LPS is a striking activator of the alternative pathway. You can see here that polymethyl methacrylate can reduce classical pathway activation, but also an almost 100% inhibition of the alternative pathway. So, using a different filter, we have a complete inhibition of the complement classical activation. Consider that there are a lot of pharmaceutical companies investigating drugs to inhibit complement. With this data, we show that with a filter, we can have almost 100% complement inhibition, especially of the alternative pathway, that is the amplification loop of the complement. We use also another approach investigating by a microarray the activation of circulating leukocytes. And in this system, with this complex system, you see the comparison of the whole genome gene expression in swine leukocytes. You can see here at the center where LPS can induce an activation of leukocytes, and here on the right, polymethyl methacrylate can really change the macroarray, the gene expression of the LPS-induced AKI. Again, we have now on leukocytes data that with this treatment we can change the genetic profile of peripheral leukocytes. And when we started to investigate the single gene, then we found really interesting data, because we found immune modulation by PMMA, for example, downregulating here the granzyme B, and downregulating the complement factor B in leukocytes. So we have also the capacity to modulate, to downregulate this potent molecule of the immune system by changing the type of filter. Then we also investigate other complement inhibitors like C4 binding protein that is upregulated by PMMA and other inhibitors of complement. So you can really have a completely change in the modulation of the immune system when you use a different approach by adsorption technique. And then we have to think about a situation like COVID-19, in which the complement system is overactivated. And in this setting, there are also studies trying to inhibit with a therapeutical target with the drugs to inhibit complement, because in this setting it has also been demonstrated a striking complement activation. And this is one of my last slides, in which we have to see the complement in its complexity, and this is really a recent review of Nature Reviews Immunology by the group of John Lambres in Philadelphia. You can see the classical, the lectin, the alternative pathway, and this is important for us because we have the activation of all the three pathways in our patient with acute kidney injury. And this is important because we are looking for therapeutic targeting of this system with the drug, but we have also data that we can interfere with complement activation with the filter. And in the latter part, this is also another interesting point of the research, that is the complosome, so the capacity of the complement to be activated within the cells. So the complement is not only activated outside in the circulation, but also within the cells. And in our data, I show you that the complement factor B is downregulated as production in peripheral leukocytes by a different technique, by PMMA. So with PMMA, we can modulate the circulating complement activation, but also the tissue complement activation and the peripheral leukocytes, like factor B or C5b, C4 binding protein. So in conclusion, in our model, we have tested this new approach, and we have functional data that we have a reduction in creatinine levels, so a protection from acute kidney injury, a better urinary output, but also an immune modulation with reduced deposition and damage, with reduced renal fibrosis, reduced factors of renal senescence, but also modulation of the circulating leukocyte by this new approach. And we are going to also test this preclinical data in humans, because this sequential extracorporeal therapy is now available, and we hope that we will have nice data like in animals. Thank you very much for your attention.
Thank you for keeping the time. We're going to have the questions at the end. So you can be here in the table, or you can be downstairs, but at the end we will be all together here in the table. So it's my pleasure to introduce Dr. Silvia De Rosa from Trento, Italy, and she's going to discuss about early recovery for multi-organ dysfunction, bridging with polymyxin hemoabsorption in septic shock.
Thank you. So, as we know, we have, when we have an infection, we have an insult, we have triggers represented by PAMPs and DAMPs. In this case, our PAMPs is LPS, and we have a sensor represented by path recognition receptor. And after, we have a trigger of a septic response with the leukocyte activation complement, coagulation, necrotic cell death, and from one side we have pro-inflammatory response with excessive inflammation with the explosion of cytokines, and the other side we have immunosuppression that allow to the body to have an increase of secondary infection and can comport the late mortality. But LPS, as we can see here in the figure, is composed by polysaccharide that is hydrophilic part, and the lipophilic part is represented by lipid A, and lipid A is the virulent part, and can be different by microorganism. And at the same time, when we have an infection, we have also to consider that there is a genetic diversity, there is a different based on gender, age, underlying disease, microbiota, ethnia, smoking, alcohol, so also how we conduct our life, and also viral reactivation. What we can have is that LPS could be also characterized by modification. So although much is known about the complex structure, synthesis, regulation, transport of LPS, we have still a question that remain unanswered. And also, there are various strategies that are employed by gram-negative bacteria to adapt to their cell surfaces, and they are still ongoing the studies about it. And although we have also to consider that for some microorganisms, LPS is not essential, for example, Neisseria meningitis is Acinetobacter baumannii and Moraxella catarrhalis. In the same time, we have also to consider that if we read some studies, for example, murine model, we have a high resistance to endotoxin, but if we consider the humans, we have a high sensitivity. And after this trigger, this inflammatory and this dysregulated host response, we can have a multi-organ failure, and we can have also endotoxin-induced organ damage. So we can have cardiomyopathy, we can have sepsis-induced AKI, sepsis-associated ARDS, encephalopathy, sepsis-induced immune suppression. So we have to block it. In the same time, we have also that we have antibiotics. Antibiotics can have a different, in critical ill patient, PK and PD parameters, and we have also new antimicrobial new drug that should be, also tested when we consider also endotoxin. This because when we give an antibiotic to our patient in gram-negative bacteria, could be, an explosion, and we have a high increase of endotoxin concentration. And we just saw this several years ago. Studies are based on cultures, and we saw that if we give some antibiotics, we can have a high also endotoxin release, or intermediate or low, and it depends also based on bacterial mass. So if we have high bacterial mass, we can have also high endotoxin release. So in this scenario, using blood purification is a bridge treatment. So we have to treat our patient managing with antibiotics, and we have to do source control, but sometimes we have no time. And so using such a blood purification therapy, we can go straight on endotoxin, and we can remove this kind of trigger. So we can lowering endotoxin levels, but at the same time we have to manage also cytokine storm induced by the release of LPS. And for this reason, in patients with septic shock, extracorporeal blood purification therapy, through the removal of endotoxin, cytokines, and bacteria toxin, can modulate inflammatory response, and we can reduce endothelial and multi-organ disease. So we are applying, in this case, immunomodulatory support. If our patient is with a renal failure, we have also to support renal function, but we are also applying multi-organ support, and in this case, we can perform renal support that with some, filter could be also immunomodulatory support. So we are talking about hybrid support. This is, the rational sequential extracorporeal therapy. So if we have endotoxic shock, we have a high increase in LPS, so we have to apply such extracorporeal HemoAdsorption targeting LPS, and after, if our patient is renal failure, we can keep going to make a support in sequential way, because what we want to do is to, restore organ crosstalk. So for this reason, when we perform the EDCI consensus, we try also to make an order, because there was such confusion about all extracorporeal blood purification therapy available. And in case of immunomodulatory support, and the removal endotoxin is a selective removal, and could be performed using HemoAdsorption. And the characteristic is that adsorption is that influence molecule membrane interaction and are typical for each molecule and for each particular membrane. But where we choose the device, we should also to assess the device adsorption capability. And also we have to assess the endotoxin burden of our patient, which is the quantity of circulating LPS that in a patient affected by septic shock. And we know that from medic trials is equal over 0.6. So according to the endotoxin dose response curve, an endotoxin activity value of 0.9 respond to 9 4 nanogram per milliliter. So if we consider an adult patient with endotoxic activity 0.9 and the blood volume 5 liters, we are talking about around 20 microgram. And we have also to consider the interstitial space is something that is 13,000 milliliter. So in this case, endotoxic activity 0.9 is equal around 52 microgram. So what we need is a device that is able to go over this endotoxin burden. And because when we have endotoxic activity, say, over the 0.9, we have over 52 microgram, and we know that high endotoxin activity levels correlate with a high mortality risk in septic shock. Even there is no identification of gram-negative microorganism. So how we can remove? We know that PMXB is a polycationic aminophilic cyclic decapeptide antimicrobial developed from Bacillus polymyxia. And we know that if we administer intravenously, we can have really high nephrotoxic and neurotoxic effects. So since 1994, Polymyxin B has been bound and immobilized to polystyrene fibers, and we have such a net where is immobilized the polymyxin B. It could be, a roll. The roll is inside the cartridge, and the flow, the blood flow is from inlet and is against the wall of the cartridge. So when we have the endotoxin border with over 52 microgram, we can remove with the Torimyxin, so polymyxin B HemoAdsorption, a quantity around 64 microgram. So we can go against the endotoxin burden. And in the same time, we are doing immunomodulation because we are not just removing LPS, but we are increasing also the expression of HLA-DR on monocyte and the CD16 on granulocyte. We are decreasing the number of CD16 and CD14 plus monocyte. We are increasing the percentage of Treg in the peripheral blood circulation. And we are also making attenuation of pro-apoptotic activity. So we are also to make an action on monocyte activated. So what we have in literature, I think that all of us knows these studies, but just to make a recap. So we have the UFAS randomized control trial that was performed in Italy, 64 patients, and was the use of polymyxin B hemoperfusion. There were patients with abdominal shock versus conventional therapy, and the absolute risk at 28 days improved significantly from 53% in the conventional group to 32% in the PMX-HP treated group. But in this patient, was not performed endotoxic activity. After we had the French randomized controlled open-label multicenter study, 240 patients. The 20-day mortality was assessed in patients with septic shock due to peritonitis. And so the eligible patients were randomized to standard care versus standard care plus PMX-HP. But 20 days mortality was so high in PMX group compared to control group, although it was not significant. But in this study, they had a lot of technical issue and based on coagulation of circuit. So we have to take care of it when we consider also this study. So the next study was a multicenter blind sham randomized control trial conducting 50 ICU in the United States and Canada, 450 patients. Patients eligible were with septic shock and confirmed endotoxemia using endotoxin activity assay greater than 0.6. And no difference was found, but the trial showed that in some patients with septic shock, the burden on endotoxin activity was extreme. So they made an amendment of the protocol, and they suggest the lack of effect in the patient with the mods of 9 or less, and those patients were excluded. And after they perform using the same endpoint post-hoc analysis. And they assess the impact of PMH use in patients with septic shock and endotoxic activity assay measure between 0.6 and 0.89. And what they found was the mortality at 28 days was less in PMH HP group. So although we have not really strong data concerning 20-day mortality, we also know that we have, if we consider all studies, we have a positive data. They are in favor of PMX HP treatment. And although we have some studies that show a survival benefit in patient treated, concerning the timing, there is not really, huge evidence concerning the timing, but we know that probably if we initiate this treatment, particularly in patients with intra-abdominal shock, within 90 hours after catecholamine treatment, we can decrease mortality. And particularly in patients with the SOFA categories of 7, 9, or 10, 12, we can have, an improvement in survival. So those are data. Recent data from EUFAS registry, and those patients were assessed from 0 to 120 hours based on endotoxic activity, was performed day by day. And what we found was that in patients with a high endotoxic activity resolving within 48 hours after the inclusion of the study, the endotropic score reduction was faster, and those patients require less RRT over the ICU stay. And also there were an improvement on endotropic score, lactates, and SOFA score. So what we also decided to do with the Italian Society of Nephrology and the Italian Society of Anesthesia and Intensive Care was to also to consider the data of Euphrates. And so we made a consensus statement. So for patients with septic shock with MOD score over 9 and endotoxic activity assay level ranging from 0.6 to 0.9 are those who may mostly benefit from polymyxin B hemoperfusion. And although the results on mortality are still unclear, and we know, endotoxic removal has been shown to improve organ dysfunction and is assessed by sequential organ failure assessment score. So probably the decision to start Stearman-based or local clinical practice, and we should consider that we are really center expert on this treatment. And we also suggest, a flow chart to measure. So after first hour bundle, patient in a frame time, there should be not so high, not so less, around 6. They should perform endotoxic activity test. And they have to consider that if the test is less than 0.6 or 0.6 over with the confirmed positive blood culture from a gram-negative pathogen, they should start this kind of treatment, and they should assess also renal function. So if there is a KDIGO stage 2 or 3, probably they have to, based on absolute indication RRT, they should consider sequential extracorporeal treatment. But above all, what is important is to have protocol, to have a good training, to have to be aware that during extracorporeal blood purification, pharmacokinetic, pharmacodynamic issue, antibiotic is really important. So TDM should be mandatory, but mandatory is create a multidisciplinary team, and the multidisciplinary team should be composed by nephrologists, intensivist expert of extracorporeal blood purification. There should be performed a really structure concerning also the laboratory, and this kidney replacement therapy team should assess the patient over the time in order to properly continuously adjust the extracorporeal blood purification based on patient needs. And this was we did also during COVID-19 pandemic. These are recent study of my experience concerning polymyxin B HemoAdsorption. We consider over 531 septic shock between 2016 and 2029. We consider the treatment for 61 patients. And before, we had, before 2019, we have no flow chart. We have a really expert team, and the assessment was performed based on criteria, Survive Sepsis campaign criteria 2016. After 2019, we apply the first hour bundle, and we start with also flowchart inclusion criteria, and we assess endotoxin activity day by day until 120 hours for enrollment. So if we consider overall cohort, we have, particularly in patient with in the post-flowchart group, we have patients with also community-acquired pneumonia. So we're not just patients with abdominal infection. And for the pre-flowchart group, not all perform twice the dose of polymyxin B HemoAdsorption to treatment. The treatment was performed in the post-flow chart in all patients, and at the same time was assessed also the starting of 30 treatment that were just in patients with acute pancreatitis. And in the post-flowchart group, we use a higher volumes of heparin, and that was followed by significant lower infusion rate on fractional heparin. And but everything was taken in control, but also kidney replacement team group. We have a lower in both group of endotoxin activity. Endotoxin activity in post-flowchart was assessed day by day. It was lowering, and there was an improvement of vasoactin entropy score, mere arterial pressure, lactates. But what we saw was that in post-flowchart group, mortality was less, 21%, 28 days mortalities. Also, we assess also AKI based on both criteria or single criteria, and we assess the use of sequential extracorporeal therapy, and 82% consider overall population were in acute kidney failure. And also the renal recovery was better in the second group. We perform also post-hoc analysis, and in the post-hoc analysis was significantly the mortality 90 days and ICU in post-flowchart group. So we need randomized controlled trials. So to conclude, we have to consider this kind of treatment. We have to consider dynamic monitoring. We have to consider that we need a team, and we need adequate knowledge to perform this kind of treatment. And in my opinion, this treatment is safe blood purification therapy and should be considered for management of unresponsive endotoxic shock. Thank you.
Thank you, Dr. De Rosa, for a very comprehensive talk and keeping on time. We will have the question at the end. Now it's my great pleasure to present the next speaker, Dr. Hofmaenner from the University of Zurich, who's going to talk to us about extracorporeal CO2 removal as a bridge to early lung recovery. All yours.
Thank you very much. Thank you for the kind introduction, chairs, dear audience. I welcome you to this last talk of this session on extracorporeal CO2 removal as a bridge to early lung recovery. These are my conflicts of interest for this talk. And I briefly want to show you what I would like to discuss with you. So first, I would like to start with some physiologic considerations on CO2 removal. So how does it work? When, how, what happens with the gas exchange? Second, we will touch on indications for ARDS. Third, we will cover some aspects in COPD patients. And then I will end up with a brief summary. So let me start with some physiological considerations. On the left panel, you see oxygen and CO2 content within the blood, depending on the respective partial pressures of those gases. And what you see here is the steep line is the CO2. So you see a very steep increase in CO2 already if the partial pressure changes only slightly. Whereas in contrast, for the O2 dissolution curve, we see a sigmoid-shaped curve that we know from the physiology books. And this means that for a given change in partial pressure, the delta for the CO2 is much higher than for the oxygen. This is what happens physiologically. You see here the carbonic anhydrase system in the erythrocyte. And this is quite a fast equilibrating system. So this is fast-stepped enzymes that can convert bicarbonate to CO2 very quickly. And this makes a lot of sense. The gases equilibrate very quickly. So you need much less unit of blood to shift to change CO2 than to change oxygen. So this means, compared to ECMO, we can perform effective CO2 removal with much lower blood flow rates. So this is a bit of physiology in terms of the devices. So you see the surface of an exemplary filter is 1.8 square meters, for example, and the priming volume is around a deciliter. And those devices the VCO2 of those devices is around 100 milliliter per minute. And this means, in terms of human physiology, that we can remove around 50% of the VCO2. Then the total priming volume is around 250 milliliters, and we run blood flows around 450 mLs per minute. So if you compare it with ECMO, for example, there we have 3, 4, 4.5 liters per minute. And here, as I told you in the previous slides, we can exchange the gas with much lower blood flows. This is how a circuit is built up. So normally we have a double lumen catheter in the patients, and the blood goes out, it goes into the filter, and it comes out to the patient again, and we do an effective CO2 removal. Normally the gas flow is around 10 liters per minute. We can adjust it, and the more the gas flow is, the more CO2 we can remove. This slide shows you a correlation between the VA, so this is the alveolar minute volume, on the x-axis, and on the y-axis you see the CO2. And the higher the ventilation is, the lower is the CO2. And normally we shift around 4 or 5 liters. And when we incorporate the CO2 removal, we can change or shift this curve, and we only need to use around 50% of the minute volume. So how do we do it practically? I told you that we use these blood flows. Of course, we need a regular monitoring of the blood gases. We do it pre, post, and also systemically. As it is an extracorporeal circuit, we need to anticoagulate the patients. In our center in Zurich, we normally target an anti-factor 10A of 0.3 to 0.4. And what we do when we initiate, we run it on the maximum level normally. If we wean the device, we do not do it via the blood flow because of the clotting risk. So rather we start to reduce the gas flow and to a timely gas flow challenge to see if the patient physiology, if the native lung function is able to cope with recovery. So let me shift to ARDS. Of course, we want to ventilate the patients in a lung protective manner. We all know the ARDS trial that compared higher to lower tidal volumes. But we also want to lower the stress on the lungs. And this is, you also remember the Amato study published in 2015, that we aim for lower driving pressures. This is quite simplistic, but if we consider to perform lung protective ventilation, and let's say we have a patient that is severely hypoxemic and combined with a hypercapnic state, we would obviously rather consider ECMO. Whereas if we have an isolated hypercapnia and let's say only a mild hypoxemia, we would consider a CO2 removal device. So let me speak about ARDS, and here, in my opinion, we have in principle two main indications. So on the one hand, we can do a rescue ventilation, and this means we want to avoid normal too high driving pressures, for example, and this is accepted titles of around 6 ml per kilogram. But on the other hand, this is a concept that emerged only recently. We speak about the ultra-protective ventilation, and this is when we speak about titles that are below 4 ml per kilogram. And those are the two main indications, and I will show you some studies that have been published on these two kind of paths. So this was one of the first studies published in 2017 from our cohort in Zurich. We included 20 patients with hypercapnic failure, and within 8 hours of initiating a CO2 removal device, we were able to lower the CO2 from 10.6 to around 8, and we saw a rapid increase in the pH from 7.2 to 7.3, and we were able to protectively ventilate those patients. So you see the titles were around 5, and we had peak pressures below 30 millibars. And what you see in the graphs is that mainly the changes occur pretty quickly, so it's almost like an exponential decrease in the arterial PCO2. So after a couple of hours, you can reach these new physiologic equilibria. And the same is with the pH, that increases quite quickly. So it doesn't take 4 or 5 hours. You can reach those better or more physiologic values quite quickly. So what is lung protective ventilation? And this is a bit a semantic question, but let me show you a patient on the left-hand side. This is an ARDS patient that has only small non-recruitable parts in the dorsal areas of the lung, whereas here you see huge consolidations, dorsobasal, and large non-recruitable areas. And the point that I want to make here is that even if you ventilate a patient with 6 ml per kilo, you might induce stress in large non-recruitable areas. For example, this might be a patient that could profit from a CO2 removal in order to limit stress to the lungs. So what do the international studies say? Of course, you remember the Supernova study that included around 100 patients in 23 centers. This was a study that aimed to analyze ultra-protective ventilation. So the aim was to reduce the titles from 6 to 4 and to keep the CO2 and the pH within a range of plus minus 20%. Patients were more or less 60 years old. You see female around 30%, SOFA score around 8, and the most frequent cause of the ARDS was pneumonia. So they had also secondary ARDS included, but mainly pneumonia as a cause. And you see PEEP around 15, pH 7.3, so those patients were kind of at the upper limit of what we would consider protective. What did the study show? Also here you see on the x-axis the hours. Within a couple of hours, the authors were able to show that the titles could be reduced from 6 to 4 within 8 hours. Respiratory rate goes down, the minute volume goes down, driving pressure can be kept around 10, which is quite protective. So all those parameters could be changed very quickly. And so the authors suggested, of course, this is feasible to do. Survival assessment was not the primary aim, and they suggested to do a randomized study. Of course, we should also consider adverse event. They had 6 serious adverse events, and what maybe is a learning thing for studies to come is that Supernova only included 4 patients per center in average. So what about the learning curve? What about the methodologies and devices? So those are certainly things to consider in upcoming studies. Then the REST study is more recent, published in 2021, included more than 400 patients with hypoxic failure, 51 centers. And they compared CO2 removal with standard care. They had around 200 patients per arm, and the objective was again to reduce titles from 6 to 3. Again, here, age around 60, and men were about 70% of the patients. And here, what the authors also demonstrated is that already at day 2 and 3, the patients treated with an extracorporeal CO2 removal device had lower titles and also lower driving pressures. The PEEP was kept quite the same over the 7 days, and also plateau pressure was kept between 20 and 30. The trial analyzed survival and was not able to show a survival benefit, but what we should keep in mind is that this trial was terminated after only 44% of the power calculation, and the trial was stopped early despite they didn't achieve certain stopping rules. So probably a better signal would have been achieved if just more patients would have been included. So for those who are more interested, there are recent consensus guidelines where some experts in the field stated targets, initiation criteria for the ultra-protective ventilation in ARDS, but also in COPD, where I'm going to speak about in the next 5 minutes. So this is just as an example at the table where you see when could you try or consider an initiation of a therapy, what are the targets for ultra-protective ventilation, and how would you wean a patient, for example. So let's move on to the second arm, to the acute exacerbation of a COPD, and also here we have kind of 2 possible pathways. On the one hand, we could try to avoid intubation, but in the other path, we could also try to bring the patients away from the ventilator. And what do the studies show here? One study was published by Del Sorbo in 2015, and they treated patients on NIF for acutely exacerbated COPD. And they had around 20 patients in 2 arms, and they took an old cohort to match the patients with a gene match technology. Patients were more than 70 years old and had a Charlson comorbidity indices around 4 to 6. And one arm was treated with NIV plus ECHO2, and the other arm was just treated via NIF. And what the authors suggested here is that you can avoid intubation in more than 50% of the patients. And the authors declared that the device was quite well tolerated also in awake patients where you try not to intubate them. And the intubation rates were 12 versus 33% in this initial study by Del Sorbo. They performed the sub-analyses, and they also showed that ECHO2 might be beneficial in patients with a low PF ratio. But what is quite interesting in my mind is they assessed the Kelly score, which is a score to assess neurological impairment. Even in those subsets of patients, the authors suggested a benefit. Of course, with those low patients number, probably survival is not the best outcome, but they suggested that hospital mortality might be better in the group treated with CO2 removal. Then the second study was published by Braune in Intensive Care Medicine in 2016. It was also a case control study. They included hypercapnic failure treated on NIF, and they matched their cohort with a historical control cohort, and the matching criteria were not genetic, but they were rather relying on diagnosis, on subscores, and on the pH of the patients. And again here they could show that intubation rate could be lowered significantly, so in more than 50%. Of course, as that's just nature, 7 patients had to be intubated because of failure of the device, and the authors were able to show again that PCO2 can be lowered quite quickly, pH increases quite quickly. Again here, adverse events should be considered, and to me, this is rather a hint that all people that use those devices should be aware of those and take those into account when treating those patients. So what's in ventilated patients? The last study I'm going to show you, published by Deal, this was prospective, a prospective study in 12 intubated patients and also around 60 years old. Again, here they were able to show that the physiology can be corrected quite quickly, and they, as an add-on, they used esophageal catheters, and they could show that the work of breath is also reduced in the people that get this device. And again, here in the publication by Alan Comp, in this expert panel, you see this, just as an example, the tables on how you could initiate the device and how you would wean the patients for those who are interested. So what shall the future do? This is just to show you, it's still an ongoing discussions of how we select patients, and a colleague of my group assessed if the PRESERVE score would be able to discriminate those patients well, the score that we normally use in VV ECMO. And the area under the curve was 0.8, which is actually quite good. Certainly we need further studies on this issue. To conclude, we can remove CO2 from a given volume of blood, and the content that we remove is much larger than the oxygen shifts. We can run those systems with low flows, and we can remove up to 50% of the VCO2. We just need a normal double lumen catheter, like also, for example, for renal replacement therapy. We can also use those devices in series. And of course, we should bear possible complications in mind, such as bleeding, clotting, etc. Thank you very much for your attention.
Thank you, Dr. Hofmaenner. A lot of insights in your presentation. So please, I invite the three speakers now to the table, and we are going to open the session for discussion. So if there is any question in the audience, you can go to the microphones. Also, we are paying attention to the questions you are making in the chat, but by now there is only one question in the chat, so I encourage you to make more questions. If not, we are going to start. Yes, please go to the microphone.
Yes. Thank you for the presentation. And my question will be in regards to the ECO2R. So you mentioned that the blood flow of 350 to 500 milliliter will be sufficient for a reduction of 50%. Does it apply for all the indications in this aspect, like the ARDS and COPD similarly, or is it different?
In our experience, yes. And the point that I wanted to make is that you should avoid clotting of the devices. And you still can adjust or do individual. Of course, you treat the patients individually by adjusting the gas flow. So, of course, if you set the gas flow to only 5 liters, then you would remove less CO2, and you can see if you can reach the delta in VCO2 by setting the ventilator more aggressively. You will do it if you wean the patient, no?
So the experience of going above 500 milliliter is also there. So you would also suggest that, especially for the ARDS patients going above 500 milliliter?
We don't do it. Then we would tend to use an ECMO instead, because you reach certain limits, and if the lung reaches a certain state of disease, then also oxygenation will be impaired.
Okay, thank you.
The question in the chat is for you, Dr. Castellano. It's regarding there is any disadvantage with the use of PMA?
No, we didn't see any disadvantage at the level of coagulation. And the major advantage is this kind of immunomodulatory activity, both of the innate immune system, but also on the less activation of T cells. Also, we have the data. So we did not see any disadvantage using it, at least in the big animal like the pig.
Dr. De Rosa, I enjoyed very much your talk. I have a question regarding your decision tree. You said, okay, we need a level of endotoxin assay above 0.6, less than 0.9, and you said plus positive blood culture from gram-negative.
No, I correct myself. So if it's at 0.6 less plus positive blood culture negative, we can start. Although we have some cases in which blood culture are negative and the toxic activity is high and probably could be related to translocation.
And the second question, if I may, is that if you look to the Euphrates studies, the patients who were the most responsive to the therapy were the gram-positive patient, gram-positive infection, and the patient with no blood culture. So the question behind is to know, is the endotoxin that we have in the gut more dangerous for the patient than the endotoxin that comes with the gram-negative?
Yeah, it could be. Depends on situation, because very often after antibiotic administration, we have a high increase of endotoxic activity and we have patient in endotoxic shock. But it is in case in which we are given antibiotics. Sometimes we have patient with bladder ischemia, okay? So no bladder ischemia, a bowel ischemia, and we can have an increase in the toxic activity and we cannot find no blood culture. Sometimes with the patient with Crohn's disease or bowel disease, and we can have an increase in the toxic activity but no culture. So we have also to see which kind of patients could be, the best. But sometimes what I saw was also related to pneumonia. So probably there is alteration of microbiota also related to pneumonia.
We are running out of time, but if there is any burning question, we can try to have it. If not, I have a last one about CO2 removal. You mentioned several studies where there is a lot of heterogeneity in the devices that are used. Which is your advice for selecting the devices? Which is the capacity of CO2 removal that we need to really have an effective therapy?
So obviously there are a lot of devices on the market. I would recommend to use one device per center because, of course, you need staff trainings. You need people that recognize the complications. We all speak about staff resources and time pressure. And I think with the conventional ones, you can perform devices that deliver up to 400 to 500 mLs per minute. You can do and perform reliable studies.
So thank you. It's time to close. Thank you to the three outstanding speakers. We have covered three different topics. The possibilities of doing extracorporeal therapies are growing. You saw respiratory therapies, renal therapies, also maybe PMX hemoperfusion is more related to shock or multiorgan dysfunction, so different possibilities. All of them have a lot of future. So this is good news for the intensivists. Thank you for being here. Thank you to Estor for supporting this session, and please enjoy the rest of the Congress.